Malpresentation. Presented to Dr. Aida Bet El Razak. Done by Manal Muhammad RR. 200,811,061. Objective. At the end of this presentation, the student will be able to identify definition of malpresentation, list 4 types of breech presentation, understand causes and risk factors for each type, discuss the diagnostic procedure related to each type, count, recognize the suitable management for each type, differentiate between each type, discuss the subject of cord presentation and cord prolapsed, outline, introduction and normal presentation, cephalic presentation, occipito-posterior position, face presentation, brow presentation, coned, shoulder presentation, breech presentation, cord presentation and prolapsed. Summary and references. Definition of key terms. Introduction. Definition of key terms. A fetal presentation. The first part of the fetus that enters the pelvic inlet. Malpresentation. It is the situation where the fetus within the uterus is in any position that is not cephalic head down. Fetal position. Relationship of the presenting part to the 4 quadrants of the mother's pelvis. Malposition. Any cephalic position other than occiput anterior, fetal attitude. Relationship of the fetal body parts to each other, normally, general flexion. Presentation. Presentation is the part of the fetus which occupying the lower uterine segment. Presentation may be cephalic 95%, breech 3 to 4% at term, oblique lie 1 to 200, shoulder 1 to 200. When the head is present in the lower uterine segment, cephalic. The presentation may be vertex 99%, face 1 to 500, brow 1 to 1500. During the antenatal period, it is difficult clinically to diagnose that the presentation is vertex, brow or face, so it is used to say cephalic presentation. Vertex 99%, face 1 to 500, brow 1 to 1500. Vertex presentation. April 20, 2017. Vertex presentation. The vertex is the area between. Is the commonest presentation. 99% of the cephalic presentations. The vertex is the area between lambdoid suture and posterior fontanelle. Parietal eminence. Coronal suture and anterior fontanelle. Vertex has transverse diameters. Biparietal diameter 9.5 cm. Bitemporal diameter 8.5 cm. Bimastoid diameter 8 cm. Subparietal supraparietal 9 cm. Longitudinal diameters. Occipitobregmatic 9.5 cm. Suboccipitofrontal 10.5 cm. Occipitofrontal 11.5 cm. During the fetal life, the fetus can take the suitable comfortable position. The position is the relation shape of the denominator of the presenting part to the pelvic brim. The position of the presenting part can be right or left, anterior, transverse, posterior, direct occipito-anterior, OA, 3%. Direct occipito-posterior, up, 2%. Right occipito-anterior, ROA, 7%. Left occipito-anterior, LOA, 7%. Right occipito-transverse, ROT, 35%. Left occipito-transverse, LOT, 40%. Right occipito-posterior, ROP, 3%. Left occipito-posterior, LOP, 3%. The biparietal diameter 9.5 cm. When the head presented as vertex anterior, it is fully flexed the chin near to the chest. Most of vertex anterior presented by transverse diameter. The biparietal diameter 9.5 cm. Longitudinal diameter. The sub-occipitobregmatic 9.5 cm. Vertex anterior. Occipito-anterior. Right occipito-anterior, ROA. 4 degrees of head flexion. 4 degrees of head flexion, indicated by the solid line, the occipitomenal line. The broken line connects the center of the anterior fontanelle with posterior fontanelle. A flexion poor. B flexion moderate. C flexion advanced. D flexion complete. Note that when flexion is complete, the chin is on the chest, and the suboccipitobregmatic diameter, the shortest anteroposterior diameter of the fetal head, is passing through the pelvic inlet. Synclitism. The sagittal sutures of the head present midway between the symphysis and sacral promontory. Asynclitism. The sagittal sutures of the head deflexant towards the symphysis pubis or post towards the sacrum. Anterior asynclitism nidulus obliquity. Posterior asynclitism lidsmans obliquity presentation. Occipito-posterior position. Suboccipitofrontal 10.5 cm or occipitofrontal 11.5 cm. When the head is presented with vertex posterior op, it will be deflexed and the longitudinal diameters will change to suboccipitofrontal 10.5 cm or occipitofrontal 11.5 cm. Occipito-posterior position op. Diagnosis. Antenatal. Diagnosed is important at least to rule out any major causes which may be a contraindication to leave the patient into labor. Suspension during antenatal examinations raise when high head. Large amount of head is palpable. Fetal back is placed posterior. The sinciput is lower than the occiput. Occipito-posterior position op. Diagnosis during labor. Vaginal examination during labor. High presenting part. Anterior fontanelle felt near to the symphysis. Posterior fontanelle felt near to the sacral promontory. Frontal sutures and frontal bones. Orbital ridge and nose. Occipito-posterior position op. Possible etiological causes. Maternal. Fetal. PG. High assimilation angle. Bicornate uterus. Septet uterus. Fibroid uterus. Pelvic tumor. Non-gynecoid pelvis. Post-traumatic. Contracted pelvis RDA. Post-poliomyelitis. Prematurity. Multiple gestation. Polyhydramnios. Oligohydramnios. Large fetus. Large fetal head. Congenital abnormalities. Cord around the neck. Neck tumor. Occipito-posterior position op. Complication. Maternal. Fetal. Rupture of fetal membranes. Marked molding. Cord prolapsed, fetal distress, fetal death, prolonged and complicated labor. Maternal distress, dehydration, ketoacidosis. Infection. Obstructed labor, uterine rupture. APH-PPH, maternal death. Management diagnosed before labor. Exclude any major cause lead to OP. Plan the further managements. Explanation and advice. Type of delivery. When. Arrange the necessary investigation. Mechanism of labor in OP. 75% of the vertex rotate from the posterior position to anterior position and deliver as occipito-anterior. 5% of the vertex continue labor in posterior position and deliver as face to pubis. 20% will end as deep transverse arrest and need to be delivered by vacuum rotation, by rotational forceps, by cesarean section. Mechanism of labor for right occipito-posterior position, anterior rotation. 0. Occipito-transverse. Brow presentation. Brow presentation. In brow presentation, the head is deflexed. The longitudinal diameter will be mento, vertical 13 cm. Most of cases of brow presentation diagnosed in labor. In early labor, minor deflection attitude are common. When the uterus contract, the head will either more flexion attitude, vertex, head staying midway between extension and flexion attitude, deflexed attitude, brow, full extension face. If the degree of deflection of the head increases, the presentation will change to brow, where the longitudinal diameter will be mento, vertical 13 cm. When the degree of deflection is increased further and the head become fully extended, the presentation will be changed to face. The longitudinal diameter is submento, bregmatic 9.5 cm. Possible etiological causes. Brow presentation. Possible etiological causes. Maternal, fetal, PG, high assimilation angle, bicornate uterus, septate uterus, fibroid uterus, pelvic tumor, non-gynecoid pelvis, post-traumatic contracted pelvis RDA, post-poliomyelitis, prematurity, multiple gestation, polyhydramnios, oligohydramnios, large fetus, large fetal head, congenital abnormalities, cord around the neck tumor. Diagnosis. Majority of cases are secondary. Primary cases will occasionally be diagnosed during antenatal follow-up. Suspension during antenatal examinations. Raise when high head, large amount of head palpable on the same side of the back, deep depression between the back and the head. Vaginal examination in early labor. High presenting part. Anterior fontanelle. Frontal sutures and frontal bones. Orbital ridge and nose. Complication. Maternal complication, fetal complication. Increase in maternal and fetal morbidity and mortality. Maternal complication. Rupture of fetal membranes. Prolonged and complicated labor. Maternal distress, dehydration, ketoacidosis. Infection. No engagement of presenting part. Obstructed labor, uterine rupture, maternal death. Fetal complication. Rupture of fetal membranes. Cord prolapse, fetal distress, fetal death. Marked molding. Management of brow presentation. Brow presentation is not suitable for vaginal delivery because of the large longitudinal diameter. If brow presentation diagnosed in early labor with no maternal or fetal compromise, we may wait and review the condition after 2 hours. If still brow, emergency cesarean section. If brow presentation diagnosed in established labor with signs of obstructed labor, emergency cesarean section. Face presentation. Full extension of head over the neck. Possible etiological causes. Face presentation. Possible etiological causes: maternal, fetal, PG, high assimilation angle, bicornate uterus, septate uterus, fibroid uterus, pelvic tumor, non-gynecoid pelvis, post-traumatic contracted pelvis RTA, post-poliomyelitis, anencephaly, prematurity, multiple gestation, polyhydramnios, oligohydramnios, large fetus, large fetal head, congenital abnormalities, cord around the neck, neck tumor, Lieutenant Mindo post, longitudinal lie, face presentation, left and right anterior and posterior positions. Diagnosis: majority of cases are secondary. Primary cases will occasionally be diagnosed during antenatal follow-up. Suspension during antenatal examinations raise when high head occiput higher than sinciput. Large amount of head palpable on the same side of the back. Deep depression between the back and the head. S shape of the fetal spin. Vaginal examination in early labor. When the cervix is sufficiently dilated, vaginal examination is helpful. In face presentation we should recognize the orbital ridges, the eyes, the nose, the mouth. Complication: increase in maternal and fetal morbidity and mortality. Rupture of fetal membranes, prolonged and complicated labor, maternal distress, dehydration, ketoacidosis, infection, no engagement of presenting part, obstructed labor, uterine rupture, APH-PPH, maternal death, maternal complication, fetal complication, rupture of fetal membranes, cord prolapse, fetal distress, fetal death, edema of the brow, marked molding. Management if the presentation diagnosed before labor. Exclude pelvic contraction. Estimate fetal size. Exclude fetal abnormalities. Minto anterior position, can deliver virginally. Management in labor, small black square, proper clinical assessment. Small black square, review antenatal chart. Small black square, insert large pore IV line. Small black square, take the necessary investigation. Small black square, keep patient fasting during labor. Small black square, start IV fluids to prevent maternal dehydration and ketosis. Small black square, use partogram for labor progress assessment. Small black square, continuous fetal monitoring. Small black square, provide adequate analgesia. Small black square, regular observation of maternal and fetal condition and the labor progress. Small black square, be ready for operative intervention, either vaginally or abdominally, and inform the neonatologist, anesthesia and operation theater staff. Mechanism of labor in Minto anterior position. As labor progress, increase extension, with Minto Chan leads. Descent. Engagement in the transverse diameter of the brim. Further descent. Rotation anteriorly to bring the mentum towards the symphysis pubis. Further descent, mentum will escapes under the pubis. Flexion of the face allows the birth of the head. Delivery of the shoulders. Delivery of the body, placenta. Mendo-posterior position. If the chin rotates posterior and presentation becomes mendo-posteriorly position. Vaginal delivery is not visible, emergency CS. Mechanism of labor in mendo-posterior position. As labor progress. Increase extension, with sinciput leads. Descent. Engagement in the transverse diameter of the brim. Further descent, the mentum is carried to the hollow of the sacrum. Descent continues, the occiput crushes into the shoulder. The occipital bone is behind the pubis. No further descent, obstructed labor, breech presentation. Breech presentation. Breech presentation. Breech presentation. Breech presentation. The nearest part of the fetus to the pelvic brim is the buttocks and lower limbs. The denominator in case of breech is the sacrum. Incidence depends on the gestational age of the fetus. Before term between 28-36 weeks 10 to 15%. After 37 completed weeks 3%. Types: complete breech, flexed breech. All joints are flexed. The feet presence beside the buttocks. Incomplete breech, extended breech. Extended knee joints with flexion of the hip, frank breech. Extended knee and hip joints, footling breech. Etiology: prematurity, fetal abnormality, multiple pregnancy, polyhydramnios, oligohydramnios, placenta previa, uterine abnormality, pelvic masses, multiparty, complication of breech, maternal complication, increased maternal mortality and morbidity, discomfort and subcostal pain, dyspepsia, prolonged labor, distress, increased manipulation and trauma, puerperal sepsis, high incidence of CS rate, complication of breech, fetal complication, increased fetal mortality and morbidity, prematurity, SROM, cord prolapse, entrapment of the fetal head, asphyxia, intraventricular hemorrhage, fetal trauma, diagnosis, symptoms, pain under the ribs, discomfort, indigestion, hard mass at the hypochondrium, fetal movements in the lower abdomen, examination, PV examination, clinical pelvimetry, ultrasound scan, external cephalic version, complication, contraindication. Management: antenatal, ensure fetal well-being, search for causes of breech presentation, possibility of change to cephalic ECV, mode of delivery, external cephalic version, breech allowed to deliver vaginally, no other indication for CS, no other complication medical or obstetrical with breech. Estimated fetal size between 2.5 to 3.5 kilograms. Adequate pelvis. In labor. First stage of labor. Proper history. Review of the ANC records. Investigation. 4 fluids. Keep fasting. Give antiacid. Partogram. continuous fetal monitoring, analgesia, inform neonatologist, keep theater staff and the anesthetist informed. Second stage of labor: spontaneous breech delivery, assisted breech delivery. Second stage of labor: assisted breech delivery, delivery of the shoulders, Lovset's maneuver. Forceps for the aftercoming head. Second stage of labor: delivery of the head, Morisot, Smelly, fight maneuver. Forceps for the aftercoming head. Forceps for the aftercoming head. Shoulder presentation. Transverse lie. Shoulder presentation. The longitudinal axis of the fetus lie perpendicular to the longitudinal axis of the mother. Causes placenta previa pelvic or uterine mass. Multiparty pendulous abdomen. Prematurity. Oligihydramnios. Polyhydramnios. Uterine abnormalities. Fetal abnormalities. Complication: increased maternal complication, obstructed labor. Rupture uterus. Operative intervention. Increased fetal complication. Cord prolapse. Fetal trauma. Fetal death. Management. Management of transverse lie depend on the gestational age and the possible cause. Hospital admission and day-by-day follow-up. Proper clinical assessment. History, examination, investigation. Consent, search for the cause if any. Treat according to the cause. Caesarean section if labor start or at term with persistent TL, unstable lie. An unstable lie is the lie which constantly change from one lie to another. Unstable lie is associated fault with placenta previa, pelvic or uterine mass, multiparity, prematurity, polyhydramnios, fetal abnormalities, complication and managements. Same as transverse lie. Cord presentation and cord prolapse. When the umbilical cord lies alongside or in front of the presenting part while the fetal membranes are intact is known as cord presentation. If the fetal membranes rupture and the cord is felt, it is called cord prolapse. Predisposing factors: malposition, malpresentation, cephalopelvic disproportion, polyhydramnios, prematurity, complication, fetal distress, fetal anoxia, fetal death. Emergency operative intervention. CS is necessarily except if management. Cord prolapse is an obstetric emergency and delivery must be as quick as possible. CS is necessarily except if the cervix is fully dilated and the presenting part is engaged. Forceps or vacuum can be performed by experienced obstetrician. Death fetus with no other indication for CS. Allow vaginal delivery. As soon as the diagnosis is made, the cord should be handled as little as possible to avoid arterial spasm. Pressure on the cord can be reduced by displacing the presenting part by hand in the vagina or by placing the patient in the knee-chest position. Synthesis should be stopped if it was used. Investigation should be sent urgently. Patient should be transferred to the operating theater for emergency CS. The pediatrician should be informed to attend the delivery. Thank you all. Good luck. References. Books. 1.M. Amo Offie, MD, 2002, Malpresentation, Obstetrics Simplified First Ed pages, 227 to 279, been a Faculty of Medicine, Egypt. To McKinney, James, Murray and Ashwell, 2005. Malpresentation Maternal Child Nursing Second ed. Pages, 340 to 351, Elvister Saunders USA. 114.